Okay, good morning, all of you. Uh, nice to see you, all of you, once again. Okay, today we are still in otology, but almost in the end of the otology, and we are discussing. We'll be discussing about the vertigo. As you all know, the ear has a mainly two functions. One is hearing, which all of we know, but as a medical person or as a science student, we should also have a good knowledge regarding the second most common, most important functions, that is the balance of our body. Generally, in the public, then think that the balance is due to the brain, but the medical science or the science says it is only the part of the balance system. And the balance system, the anatomy is purely simply divided into the two parts, that is the central and the peripheral. And brain is included in the central system, while the ear, especially the inner ear, is involved in the peripheral part of the balance anatomy. But sometimes due to the several conditions or factors, the balance of our body has some problems, which may have simple issues or might have a serious consequences. But peripheral type of issues are it looks like a serious initially, but it does not cause a life threatening. But the central causes of this imbalance should be kept in our mind so that it should not be missed and the life should not be threatened. Technical issues or problem. Okay. Okay. In the previous lectures, it has been discussed regarding the normal balance systems and the differential diagnosis of vertigo, and this will be the second part of it. To make vertigo is a very big and a very big topic. So to make a simple, and for the MBBS student, it has been simply keeping in mind due to this past topic. It has been to make a simple. The vertigo has been divided into this due to the presence or absence of hearing loss. As you know, as you see in the serial, the vertigo with hearing loss and vertigo without hearing loss. That is the simple way of classification. When you reach the internship or in the medical officer level, when a patient comes to you in the general OPD or any OPD or in emergency, and if they say if they complain about the dizziness or vertigo, you especially you are tend to ask regarding the vertigo. whatever vertigo, when did it attack in the first time, how does it goes, and uh, like that. And the second point should be always make a habit to ask, do you have a hearing loss or not? The patient might say, I have a hearing loss, but the hearing loss should be uh, related with the vertigo. The old lady can say, vertigo, I have vertigo, but due to the presbycusis or the age-related hearing loss, she might have a hearing loss, but not associated with the vertigo. You should be able to uh, differentiate between the vertigo-related hearing loss or not. Always ask for the hearing loss. Yes, the patient might have vertigo and have a hearing loss, or after hearing loss for a few minutes or few hours or few days, I develop a hearing loss, or other way around. There may be vertigo and hearing loss, or hearing loss then vertigo. And with that 2 point, we can differentiate a few common vertiginous diseases. In the previous class, the most common type of vertigo due to the peripheral system, benign paroxysmal positional vertigo was discussed, and you should have a thorough knowledge regarding that. But it will be quite tough for you in the initial period. But that is the most commonest type of vertigo, and it is the simplest. And it can be, if the patient comes with the ideal symptoms, typical symptoms, you all can diagnose that BPPP. Apart from that, that is a simple example of vertigo without hearing loss. There is only the vestibular symptoms is there, but there is no auditory symptom, means there is no hearing loss or any tinnitus like that. Today, other examples of vertigo with hearing loss and without hearing loss will be discussed for your knowledge. Just to remind you to know the detail about the diseases, it can be vertigo can be defined simply any imbalance or rotational type of feeling by the persons or with the surrounding, or it may the surrounding may be rotated. The subject can rotate himself or herself, or the surrounding may rotate in any plane. It may be a horizontal, vertical, or torsional. And the basis of this subject, the patient's and the environmental issues, the vertigo also can be classified into two types of vertigo. That is subjective, means the patient can feel. The patient says, "म आफै घुमिरहे जस्तो लाग्छ," means the patient is rotating with the surrounding is stable, and but the patient is feeling the rotating movement. Other way, the patient is stable, but the surrounding is moving or rotating. That is the objective vertigo. As we all know, the 85% of the muscle cases are related to the peripheral type of lesions, where the vestibular end organs and the vestibular nerves are the main culprit. The vestibular system, and while the central nervous system accounts about the 20 to 10 to 15%, but they may be a serious one. These are this is table for you to just have a knowledge regarding the what are the peripheral vertigo and what are the central causes of vertigo. In the peripheral benign provision BPVP, benign provision vertigo, Meniere's disease, labyrinthitis, ototoxicity, and superior canal disease syndrome are included in the peripheral. Well, they are the commonest, more common. In the central type, migraine, multiple sclerosis, cerebral hemorrhage, brain insufficiency, vertebral artery section, any brain neoplasms may cause the central type of vertigo. And these are the diseases we should exclude or we should differentiate. So that is these are the peripheral. The ENT will treat that, and this is the central cause. The neurologists or neurosurgeons or other physicians should be consulted or not. These are the points we should be able to, or we should just keep in mind that this might be a cause that the patients are suffering from. It should be keep in your mind. And this is also the simple topic table where we are differentiating between the peripheral and the or vertigo, different type of vertigo on the basis of presence of hearing loss or the hearing loss is intact. And another component to differentiate between these vertiginous diseases, the time duration is the most important. Always after the patient says gives the complaints about the vertigo, you can ask, just ask the patient to elaborate regarding the vertigo. Then in the next questions, you should always ask for your benefit, is there a hearing loss or not, and not to forget is that always ask for the durations, whether the vertigo rotary type vertigo is for few seconds, a few minutes, hours, or it was by days or weeks. And this will be the simple classifications where you can differentiate regarding the different type of vertigo. BPPP is always comes in a second. There is no hearing loss. Is in few seconds, but there is a hearing loss, perineal fistula, or any cholesterol disease can be suspected. In minutes where there is no hearing loss, migraines or vertebral syndromes can be. Okay, and it goes for hours. Naturopathy, Meniere's disease can be discussed further with the patients, and this meningitis, labyrinthitis. It goes for the weeks. Most majority of cases due to the central nervous system diseases. And these are the few cases of peripheral as we have discussed earlier. Central causes we discussed. And there are few miscellaneous causes regarding the vertigo, but they are actually they are not the true vertigo, but majority cases comes with this dizziness. Like cervical vertigo means due to the cervical spondylosis and error of refractions, any ototoxic drugs related iatrogenic due to the surgical issues like staph surgery, the patient may come with different type of dizziness. And the diagnosis of excision like psychogen vertigo may come to you with this subcase, but the psychogenic vertigo should not be the false diagnosis. This is the diagnosis exclusion. All the possible diagnoses and the serious central causes should be excluded. Only then, apart with the help of psychiatrist, we may term as a psychosis vertigo. It may be due to anxiety, panic disorder, any phobia. Just for the example, due to this a few years back, we had a big earthquake that may also cause these types of vertigo. Many of the patients came to the ENT department and asked for this management. And now, due to the pandemic, these cases may grow or still due to this lockdown. The many of the cases are done with the respective doctors. And there, in the psychogenic vertigo, there is always absence of organic causes. The patients gives a vague and fleeting means. Sometimes they complain about the ear problem. Sometimes they say 2 years, or they don't have a strict complete symptoms. So this changes their statement differently to the doctors, or differently in the every visits. There may be a dramatic presentations or attention-seeking behavior, and usually they are usually related with the emotional stress or any type of physical or mental stress for the onset of vertigo. And these are the few the symptoms which are usually the patients may come to you with these types of symptoms, and they say the same thing. Chakkar lagyo, ringata lagyo, but we are focusing on the rotary type of vertigo, especially with durations with or without auditory symptoms. But sometimes the patient may say, "Malai bios jasta lagyo, टाउको हलुङ्गो गरुङ्गो झुम्म अँध्यारो भएछ, like just some kind of vibrations or उडेको जस्तो लाग्ने." These are the symptoms. Actually, they are not related to this peripheral type or any central type, but they should be evaluated, and they should not be termed as a type of any type of vertigo, but they are vertigo-like symptom. So regarding the vertigo and the dizziness, vertigo is, we are directing to the rotary type of vertigo or non-rotary type of vertigo, but dizziness is quite a big one. The patient may associate with this faintness, lightheadedness with the dizziness, but vertigo is the medical term which we use to diagnose the different type of diseases. But faintness and uneasiness, imbalance are related to the other causes, and they shouldn't be mixed with our peripheral type of vertigo. Okay. Today's main discussion will be the Meniere's disease, also known as the interlimbic hydrops. And in our body, we have a different organ where there is a close compartment of fluid, like ocular system, in the body we have the hematological with the blood, lymphatic system. In the same with the same examples, we in area also we do have a fluid, which are especially divided into endolymph and the perilymph, and these fluid are related to the balance systems. Sometimes, due to the unknown causes, we don't have a accurate causes of this how the Meniere's disease develops still on the they are on the scientific study, but the hypothesis has been there, and due to the faulty drainage or overproduction of this disease, this endocrine system may cause a disease or multiple symptoms related to the patient's uneasiness, and it has been termed Meniere's disease. But sometimes in your textbook, you may come through a Meniere syndrome. So for you to keep in mind, the simple way is that Meniere's disease is the primary primary endolymphatic hydros. It may simply divide into the primary and the secondary. Primary endolymphatic hydros. Primary endolymphatic hydros is the Meniere's disease. When it comes to the secondary, it might be termed as a Meniere syndrome. So, how does a Meniere's disease present? Actually, it is a syndrome, means there are multiple syndromes are there or multiple clinical features are there. There is a episodic vertigo, which is a spontaneous in nature. The patient might be okay at the time, but suddenly the patient may feel the sense of imbalance. That is the episodic vertigo. Means episodic means it doesn't come 24 hours, 7 days, or 20 days, all the month, but it comes for a few hours or days that it goes, and the patient may have the associated auditory symptoms. That is, a hearing loss is there. It might be a mild type of hearing loss, or it might be a moderate one, but there is some degree of hearing loss is there. But the patient may complain you with the hearing loss or without the hearing loss at the initial phase. But with the help of audiogram, it can be detected. Patients are usually worried regarding the vertigo and the autonomous symptoms like dizziness, vomiting, and the sweating, and they didn't worry about the hearing loss at the initial phase where it be a mild one. But the many in the Meniere disease, the another component should be always there. Initially the unilateral fluctuating sensory hearing loss. The patient also comes ready. Yo, kita no station. Okay, let's continue. Means there is a initially there the scientists or the otologist has termed the Meniere disease with a triad symptoms. That it was an episode vertigo, unilateral fluctuating sensory hearing loss, then the unilateral tinnitus. But nowadays, the another symptoms oral earfulness has been added. It might or it might not be present in the initial phase, but the most of the patients feels that there is some kind of earfulness is there, and they after that the vertigo develops. Or after vertigo, the patients may continue with the earfulness. These are the four important components of the Meniere's disease: vertigo, sensory hearing loss, tinnitus, and the earfulness. As I have mentioned few minutes early, that it can be divided into the primary and the secondary. The primary is the Meniere's disease. It the especially the cause is still unknown, but there might be a predisposing factor which are termed as which are mentioned in the secondary endolymphatic hydrops. It might be a genetic, anatomical, post-traumatic, any viral infections, allergy, autoimmune, or any psychosomatic. But not one of them or not all are been had got any common consciousness. Means no one has agreed to the single causes. So still the study or has been going on regarding this disease. So how does this happen, and what are the things that go in the area? And most of the scientists have agreed regarding the pathophysiology. There might be overproductions of endolymph, or there is a malabsorption of endolymph. Same like a glaucoma in the ear. एन्डोलिम्फ धेरै प्रोडक्सन भएर अथवा त्यसको ड्रेनेज राम्रो भएन भने there is a endolymph is volume is high, so that will cause the gross enlargement of membranous labyrinth, also termed as endolymphatic hypertension. So that will cause the periodic rupture of the membranous labyrinth, and that endolymph which are normally distance from the perilymph, now they mix with the perilymph. सुरुमा एन्डोलिम्फ र पेरिलिम्फ मिक्स भएको हुँदैन, बट मेम्ब्रेन्सहरु रप्चर भएपछि they are mixed, which causes the inactivation of hair cells and neurons of the and unknown involuntary type of neurons and hair cells are activated, and they causes the unwanted firings of action potentials that will go through the vestibular nerve to the brain, and while the brain coordinates with the balance system, which where the external inputs are from the labyrinth, eye, and the proprioceptive systems like joint, trunk, and they, due to the involuntarily unwanted firings of action potential from the labyrinth via the vestibular nerve, the brain gets confused, where it gets a message that the body is in imbalance and tries to adjust the imbalance problem, but actually the problem is in the not in the balance but in the labyrinth. So that is called, that will lead to the vertigo, tinnitus, and in the labyrinth we do have a hearing mechanism, also hearing system that is also get damaged, and earfulness. So let's get to the picture. In the first picture, this is the normal inner ears picture, but in the second, this is the area and the lymph systems area where it gets is there is a bulging is there. You can see this is the small area and it gets bulged. And the second one, this is the normal choroidal area, and this is the when the endolymph gets overloaded and there is a bulging of this membrane, and in this area there is the endolymph and it is the perilymph. The over expansion gets leads to the mixing of endolymph and perilymph, and all the symptoms then gets generated and the patient feeling the sense of vertigo. The same the picture in a Meniere disease, there is a dilatation of the symptoms. Also, the endolymph sac is swollen. Regarding the natural history of Meniere disease, in the typical cases, not always all the symptoms or all the features are present in the presence during the each visit, but majority in the typical cases, there are some stages as there. In the early stage, there is sudden vertigo is there, where the patients cannot predict when the vertigo starts or when the vertigo will lead to the problem. There might be a hearing loss and a tinnitus, hearing and full sensation returns between the attack. Means in between the attacks, the patient's hearing seems to be that the hearing has come to the normal and there is no earfulness. And while in the repeated attack, the patient might have a vertigo attacks with a less severe, but hearing loss will get worse, and the period of remission is there. And the lately, when it gets repeatedly, the duration gets short, hearing loss becomes more worse, and problems with imbalance is there. It means that initially there is a vertigo is there, but in the time durations, the repeated attack, vertigo seems to be the attack vertigo seems to be going in the less intensity, but the patient's hearing loss worsens, and sometimes it comes to the point that the patient might only feel an imbalance with the total, there might be a total hearing loss. चक्कर लाग्दैन अथवा इम्ब्यालेन्स अलिअलि मात्रै हुन्छ तर मैले कान सुन्दिनँ भने स्टेजसम्म पुग्छ भन्ने अवस्था आउन सक्छ. So Meniere disease is the continuous process. It can only be controlled. It can be eradicated, like the same as a hypertension and the diabetes. It can only be controlled, but due to the repeated attack, the patients may come to the hospital or the doctor for the management. But actually, exact management is not in our hand, and all the symptomatic treatment is there for the last decades. So Usually, the 40 or 50 years of patients are usually found to be in 40 to 50 years. Majority take it in the average. Female seems to be more in than the male, but not so much. And feminine history may be present, and there might be a few racist issues, but it's not an established one. And how do you diagnose Meniere disease? There is a in the world in the world level or in the globally there are big scientific committee has been established to study the balance regarding the vertigo, where they have a term as equilibrium committee. This is where I have mentioned in this slide is that one is the American Society and the second one is the World Equilibrium Committee, where they have reached a common ground regarding the definitions or diagnosis of Meniere disease, where initially they have discussed mentioned regarding the four types of Meniere disease: probable, definite, and most probable. But recently they have only revised and only mentioned the two type criteria for the diagnosis of Meniere disease. The first one is definite Meniere disease. The second one is the probable. In the definite diagnosis, to term or to mention or to say that this is the sure, I'm sure that this is the Meniere disease. These points should be included. There should be a 2 or more spontaneous attack of vertigo, each lasting 20 minutes or 12 hours. 12 घण्टा भन्दा माथि नभएको, but at least 20 minutes to hours. Means Meniere disease is included in the classify is included in the minutes to hours. If someone asks how much does the hours minutes time duration is there for the Meniere disease, it should be including minutes to hours. And audiometry should be documented where it shows a fluctuating low to mid frequency sensory hearing loss in the affected ear on at least one occasion before, during, or after one of the episodes of vertigo. Means audiogram is must. And there might be added oral symptoms like hearing loss, as we have mentioned in the audiogram, tinnitus, or the fullness in the affected ear, and other causes should be excluded by the other test. Means when we test or when we evaluate a patient of vertigo, these tests comes to an action, and these tests should exclude other causes where we went to term the Meniere disease. And another one is a probable. Is the where we might not be sure whether it is a Meniere disease or not. We might term it as a probable type Meniere disease, where the criteria are at least 2 episodes of vertigo or dizziness lasting 20 minutes to 20 hours, fluctuating all the symptoms. Hearing loss might be there or not, tinnitus or fullness might not be there in the affected ear, and other causes should be excluded. All the tests shows a negative for any respiratory diseases, but patients has initial 2 symptoms of vertigo for durations of 24 hours and other symptoms we might term as a probable Meniere disease. And there are few variants or different types of Meniere disease as we mentioned. When typically Many diseases, as we have discussed earlier, there is a vestige syndrome, Cochrane syndrome, or a pressure, but not all 100% patients comes with that features. But sometimes atypically the patients may come with only the vestige syndromes and oral pressures, and it is termed as vestibular hydrops as vestibular hydrops. In cognitive hydrops, only the cognitive syndrome is there, means hearing problem may be there, but patient might not have a vertigo, only sense of ear pressure and hearing loss is there. And normal ear syndrome, there is a deterioration of hearing, and there is a vertigo, and which time hearing recovers. And Turmakin's author crisis. There is a sudden attack without loss of consciousness or no vertigo, no fluctuations in hearing. Means sometimes the patients may suddenly fall with the imbalance, but there is no loss of consciousness, sudden drop. Patient हिँडिरहेछ डङ्गमा लड्छ तर किन लड्यो थाहै हुँदैन. सो पेसेन्ट बेहोसी पनि हुँदैन, चक्कर लागेको हुँदैन, कानमा त्यति धेरै प्रब्लम पनि भएको हुँदैन, तर डङ्गमा लडिन्छ. टोमाकिन्स क्राइसिस भन्छ यसलाई. धेरै देखिँदैन. ओके, टाइम ड्युरेसन म रिकर्डिङ फेरि गर्छु. म अफ गर्दैछु, फेरि रिकर्डिङ गर्दैछु है. टिचरहरूलाई भनेको हुन्छ होला, टिचरलाई त मजाले गर्छ क्या, हामी सिकाएको हुन्छ सुन्नु होइन. ओके, साथीहरू आउँदै आउँछ. 38 मात्रै भइरहेछ के हो. ओके, means के बुझियो भन्दाखेरि Meniere disease may show a typical, sometimes major cases it may show typical symptoms or sometimes a typical one, and atypically there are few terminally is there like vestibular hydrops, but the only vestibular symptoms are there. Cochlea hydrops and the cochlea symptoms there, Meniere syndrome and Turmakin's drops. For your knowledge, various type of vertigo are usually related, the patients are usually concerned regarding the day-to-day activity disturbance. Means quality life is disturbed. It doesn't cause a life-threatening issue, but due to the fall, due to the hearing loss, or due to the imbalance, their daily activities are seriously disrupted. So these are the points they are usually concerned with. And the psychological support and the good counseling is very much necessary for the part of management. Okay, let's go to the next slide. Okay, we have very much discussed regarding the clinical features previously. Vertigo, sudden, up to 24 hours, there is acute nausea, vomiting, or fullness, tinnitus, hearing loss, but there should not be a neurological deficits. Nystagmus is always present during the active stage. Sensorineural loss, low frequency, fluctuating, progressive, sensorineural tinnitus, continuous, it may continuous or intermediate nature. And usually the audiogram in the early stage, it shows the low frequency, means 125 to 50, 500, 1000 frequency are usually involved. There are a few tests just to support the diagnosis, but Mostly the Meniere disease is a clinical diagnosis. Audiogram to support to for the diagnosis criteria of Meniere disease. In some area, the speech audiometry might help special audiometry test to rule out whether this disease is due to the cochlear or is the due to cochlear one, and transtympanic electrocochleography might be a good test to be done, but it can only be done where the vertigo lab is there. Generally, these are the sophisticated test for the vertigo. Not, I think we don't have in this Nepal. Only in the closely we have only in the India, and we have a vertigo expert, the mentor in the Kolkata. The Anirban research is there, and a few years back only, the Vertigo lab with the limited facility has been established in the IMTATS, but still the most of the tests are not done in Nepal. So and glycerol test, which gives when it improves after giving the glycerol, we might diagnose a case of Meniere disease. We don't go to the detail regarding this test now. Caloric test, it shows a canal paralysis. The caloric test will be discussed in later on. How do you manage the case? Medical treatment. All the cases of vertigo which comes to you in OPD or in the emergency, when they come in the acute phase, the management is almost the same. The patient should be in bed rest, hydration be maintained due to the repeated vomiting. In some cases, we might give a injected medications like prochlorperazine, promethazines, sometimes diazepam for the patient's benefit. And in case of for the prophylactic, where the patient gets discharged, the salt restrictions, diuretic therapy, the hydrochlorothiazide is the choice. Vasodilators like beta-histines and storage and immunotherapy is still a controversial. Sometimes for the severity and the severe one, intertipin gentamicin, but not all the institutes go for this type of management. The gentamicin, as you know, it is the ototoxic. When it is given intratympanically, it will cause a chemical ablation and basic functions. Basic system China, not vertigo. But patients' general conditions should be always be managed. After the ablations, the patient might have an imbalance for the lifelong. So always think of that. For the hearing loss, okay, for hearing loss, like hearing aids are there. What is only the it's not the therapeutic, the supportive only. For tinnitus, reassurance or tinnitus masker is there. The different surgical management have been mentioned in the textbook, but this is the destructive one. In case of we can go for the endolymphatic sac decompression, in the lymphatic section to decrease the endolymph volume, and for the vagus nerve section, vagus nerve काट्यो, so abnormal sensation brain मा जाँदैन, so भटेको हुँदैन भन्ने हो. But this is the case of extreme expertise कुरा हो. And always the patient should be always discussed regarding the post-surgical issues like imbalance might be there, and the labyrinthectomy. Labyrinth छैन पुरै ध्वस्त गरिदिने भने, but this is the destructive one. Severe cases मात्रै गर्छ होला, but it is a rare type of surgery. And other differential diagnosis of vertigo we'll discuss in the short is the labyrinthitis. In the labyrinth literally means where we can get enter, but the exit is the patient gets confused and is difficult to exit out. त्यस्तै labyrinthलाई नि त्यसरी मानिन्छ, where the cochlea and the vestibular systems or semicircular canals, vestibule as a whole as taken as a labyrinth. Cochlea भने भिन्दै हो, vestibular system भिन्दै, but they are very near and they are attached to each other as a combinedly they are taken as a labyrinth. So there is this very much sophisticated organ, so is now name given as a labyrinth. A labyrinth. When it gets infected, usually infection, then the labyrinthitis term is mentioned. It can be acute or chronic, or it can be classified into bacterial or viral, but how to differentiate? This is the main point. So in the नाममै लेखेछ labyrinth. Labyrinthमा cochlea and the vestibular system is involved. So cochlea symptoms पनि हुन्छ, is there, and vestibular symptoms is also there. So this is the best example of vertigo with hearing loss. Vertigo हुन्छ, hearing loss हुन्छ. Meniere disease पनि त्यस्तै, vertigo हुन्छ, hearing loss छ. त्यो दुईटा एक्जाम्पल तपाईं याद गर्नुपर्छ. Vertigo without hearing loss चाहिँ BPPD छ, अनि अहिले basic pneumonitis पछि आउँछ, त्यो पनि हामी छोटो डिस्कस गर्छौं. ओके, अब स्लाइड अलि छिटो जान्छौं, अलि छिटो सघाउँ. There is an infection inflammation labyrinth is there. It can be simply divided into bacterial and the viral. In the bacterial, in the acute toxic, acute suppurative, chronic suppurative, fibrosis. Serous type bacterial serous मा चाहिँ we can the labyrinth can recover to the normal level. But in chronic suppurative and the fibrosis, the permanent damage may be there. Viral पनि त्यस्तै recover गर्न सकिन्छ. Rotor spread, round window, open window, labyrinth fistula due to the acute otitis media, chronic otitis media, malignancy or trauma, bacterial labyrinthitis. Internal auditory matters, cochlear aqueduct, vestibular aqueduct. Associated कसैमा there might be associated meningitis. Organism beta hemolytic streptococcus, pneumococcus, Haemophilus influenzae in the acute cases, in the chronic gram-negative bacilli. In the acute serous labyrinthitis, there is chemical changes in perilymphatic space, but it is a reversible. Management, treatment, we can manage it. Acute suppurative, there is an invasion of perilymphatic space by the bacterial organisms or is toxins when it may cause irreversible destruction might be there. कति रिकभरी हुन्छ मेजोरिटी but 100% हुन गाह्रो हुन्छ. Chronic supplemental dermatitis also causes the same type of issues. Fibrosis गरेर osteogenesis गर्ने चाहिँ fibrosis conditions मा हुन्छ. The long term issues. How does the patient presents? It is a sudden onset and there is a severe rotary vertigo is there. It goes to days to weeks. Minute disease ma minutes to hours धेरै भनेको 24 hours मेन्सन गरेको थियो. यसमा चाहिँ days to weeks भनेपछि हप्तामा जान्छ. भनेपछि पेशेन्टलाई कतिको गाह्रो हुन्छ. There is a unilateral severe hearing loss. Unilateral tinnitus भनेपछि auditory र both complex basic symptoms there. Nystagmus is always there. This imbalance 6 weeks भन्दा माथि persist गर्न सक्छ. There is a hearing loss, sensory type hearing loss. Serious type of laminitis it improves. Suppurative total and permanent. With these features, we should discuss or counsel the patients and treat accordingly. Because after the vertigo stops or vertigo recedes, the patient always discuss or always worry about the hearing loss. As a career oriented हो भने सबभन्दा प्रब्लम टोटल हेरिङ लस भयो भने जस्तै तपाई जस्तै स्टुडेन्टको हेरिङ लस भयो भने के गर्ने वकिलहरुमा गयो भने के गर्ने लयरमा बैंकमा काम गर्नेमा के गर्ने आर्मीमा गरे के गर्ने उनीहरुको त लाइफ चेन्ज कन्डिसन आउन सक्छ सो we should counsel accordingly. Investigations audiogram छ हामी गर्न सक्छौं हाई फ्रिक्वेन्सी हेरिङ लस हुन्छ severe to prevent hearing loss calibrate test गर्न सकिन्छ where there is a response कम हुन्छ x-ray mastoid CT scan to support to exclude the other causes of disease. ल कति बज्यो 6 मिनेट ओके यो टाइम अप भन्ने भाइ को हुनुहुन्छ तपाईको रोल नम्बर दिनुहुन्छ नि दिनुहोस् यो त्यतिकै बाहिर आएर पढ्नु मन लाग्दैन नि छोड्नुहोस् अफ गर्न सक्नुहुन्छ यहाँ आएर च्याटमा प्राइभेटली लेख्नु हुँदैन क्लास त सक्नु पर्यो रिकर्डिङ गर्ने कारणले गर्दा टाइम लस हुन्छ त्यो भएर रोल नम्बर दिनुहोस् तपाईको फेस देखाउनुहुन्छ देखाउनुहोस् यहाँ आएर बिचमा आएर च्याटमा आएर यसरी नलेख्नुस् आउनुहुन्छ भने फेस गर्नुस् मैले सबै स्टुडेन्टहरुलाई तपाईको आफ्नो प्रपर नेम तपाईको इमेल र रोल नम्बर राख्नु भनेको छु म एज अ कोअर्डिनेटर धेरै कम्प्लेन आइरहेछ आज म तपाईलाई भनिदिन्छु को हो चिन्न सक्यो भने एक्सक्युट गरौँ अनवान्टेड डिस्टर्ब नगरौँ क्लास हामी बन्द गर्न सक्छौं बेनिफिट अफ अल द स्टुडेन्ट्स नपढिकन एससीजीई 11 दिए जस्तो होइन यो एमबीबीएस बिरामी हेर्नुपर्छ ट्रिटमेन्ट गर्नुपर्छ मान्छेको ज्यानको कुरा हो सिक्नुपर्छ रिकरिङ गर्दा सबैलाई गर्दा डिस्कसन गर्दा टाइम लाग्छ टाइम अप र एबीसीडी को हुनुहुन्छ ल एबीसीडी ले डिस्टर्ब गर्ने हैन भनेको रहेछ ल मलाई टाइम अपलाई भनेको छु फेरि 5 मिनेट यसमा गयो ल हामीसँग धेरै स्लाइड छैन treatment as I mentioned previously acute stage the same treatment bed rest treat the vomiting status, antibodies and drug insults. Labyrinthitis is might be a cause of due to the bacteria. So IV broad spectrum antibiotics is choice of drug. Surgical management in some cases, myectomy, cortical mastectomy in chronic otitis media. If we think that is due to the cholesteatoma or issues, nested surgery could be done. In viral labyrinthitis, mumps virus, adenovirus, influenza virus are known to be cause the viral labyrinthitis, but difficult to go for the culture sensitivity. Rotor spate might be a blood, higher blood or subaqueous case, always preceded by upper respiratory infections or any type of viral infections. तपाईँले भाइरल लेमिटाइटिस टर्म डायग्नोसिस गर्नु भन्दाखेरि पेसेन्टले सोध्नु भयो जहिले नै एक दुई हप्ताभित्रमा 2-4 दिनभित्रमा मलाई रुगा खोकी लागेको थियो अपर रेस्पिरेटरी इन्फेक्सन थियो रुगा खोकी चाहिँ भएको थियो भनेर भन्छ प्रायः मिल्छ बट ब्याक्टेरियामा हुन सक्छ नहुन सक्छ अलिकति ब्याक्टेरियल लेमिटाइटिसमा हामीले हाउ टु differentiate between viral and bacterial laminitis. Ongoing process, it is very ongoing. During the ongoing stage, it is very difficult to differentiate. But this is the diagnosis, and retrogradely only we can think of that. It may be due to the virus, or it was due to the bacteria. If the hearing loss is permanent and the symptoms goes for more weeks, we may think of bacterial, but in case of viral, the vertigo is usually resolved and then there might not be a permanent hearing loss. But how many days the ENT may get recover, it differs patient to patient. So, steroid, we usually advise for the steroids for the hearing recovery. Viral antiviral agents, antiviral agents like acyclovir does not have a good role. It is still in controversy. Medical treatment same as a bacterial laminitis because we don't know it was due to the bacterial virus. So IV antibiotics only did so, but that is the ongoing practice. Bacterial pneumonitis. Sometimes in textbook you might also see a vestibular neuritis. Means vestibular nerve is involved. सीधे बुझ्दाखेरि त्यसै बुझ्नु पर्यो. Usually middle age seasonal देखिन्छ. There is a acute sustained peripheral vestibular dysfunction with nausea, vomiting, and severe vertigo and imbalance. Acute labyrinthitis and vestibular neuritis are severe dysfunctions of the nausea, vomiting, the vertigo. Always preceded by, usually majority of cases are preceded by upper respiratory infections, and imbalance may go up to the 3-4 weeks, and it is taken as a third common cause after BPPV, Meniere's disease, and then comes the bacterial pneumonitis. And the viral infections of bacterial nerve is the mostly accepted causes, and among them the herpes simplex is the mostly accepted virus for the bacterial pneumonitis. So what do we find or how do we diagnose bacterial pneumonitis? Because it is one of the commonest cause of vertigo. There is a presence of spontaneous bacterial pneumonitis. Spontaneous unidirectional horizontal nystagmus is there, where it breathes towards the healthy air, which is suppressed by oblique fixations. And the rhombic test is falls toward the disease side, and characteristic shows paresis. This is presence point. How to differentiate from other causes? There is a there is absent of hearing loss. So this is a good example of vertigo without hearing loss. तपाईले यसमा BBB vertigo without hearing loss मा BBB र vested neuritis राख्नु पर्छ अथवा राख्नुहोस्. अनि vertigo without hearing loss मा BBB र vested neuritis कसरी छुटाउने भन्ने बित्तिकै BBB few seconds मात्रै हुन्छ. यसको ड्युरेसन्स डेज देखि वीक्स सम्म जान्छ. त्यसै छुटिहाल्छ यो. र there is absence of other cranial nerve deficits, immediate infections हुँदैन, हाई फिभर हुँदैन, नेक डिजिज हुँदैन, मिन्स सेन्ट्रल इन्फेक्सनहरु हुँदैन. मिनिस डिजिज र लेब्रेन्थाइटिसमा छुटिहाल्यो. हेरिङ लस हुँदैन भन्ने बित्तिकै तपाईले लेब्रेन्थाइटिस र मिनिस डिजिज छुटिहाल्यो. तर बीबीबी त हुँदैन, एचकोनी हुँदैन भनेपछि ड्युरेसनले अब छुटाउनु पर्छ है. त्यसै छुटाउने चारवटा चाहिँ तपाईहरुको लागि इम्पोर्टेन्ट छ. त्यो भएर रिपिटेडली डिस्कस गरिरहेको छु मैले. ल ट्रिटमेन्ट, रिएस्योरेन्स, बेड रेस्ट, पेशेन्टको नेक मुभमेन्ट धेरै गर्नु हुँदैन भने हेड सपोर्ट भनेको. अब स्टिमुलेटरको नाममा आउँछ प्रोकार्पेराजिन आउँछ, प्रोमेथाजिन, फेनर्गन, डाइजेपम पेशेन्टलाई एन्जाइटी कम गर्नको लागि. अरु चाहिँ फ्लुइडहरु भमिटिङहरु अरु सबै कन्ट्रोल गर्ने हो, रेस्ट गर्ने र पेशेन्टलाई राम्रो काउन्सिलिङ गर्नुपर्छ. अनि लङ टर्ममा सिनारिजिन, पिटास्टिन दिन सकिन्छ. प्रेडनिसोलोन्स आर गुड चोइस. ओके, थ्यांक यू.